The project is about patients, characterizing patients with they present in the clinic and in the laboratory with iron overload, specifically the genetic causes of iron overload, which is the most common cause of the condition. So what I'll do, I'll just give a very brief introduction about some of the clinical aspects of the patients, and then Fayyaz, who is the brains behind the project, he will talk you more about all the clever stuff, the science around it. So iron overload, which is a common disease with a complex presentation, and it's becoming increasingly more common coming in the clinic. So it is iron overload is basically when you have iron accumulation and in the liver, joints, the endocrine, the heart, the brain, and the main cause for this condition is genetic. It's called hereditary hemochromatosis. It is very common in North Europe, in patients of North European and Celtic descent, especially Ireland and the UK. If it is untreated, and it's quite few of patients that become untreated at the later stage, so they present with liver cirrhosis, hepatocellular carcinoma. Hereditary hemochromatosis has a higher risk for development of liver cancer, diabetes, arthropathy, and other complications that decrease the life expectancy. Prevention is easy, it's cheap, but once it happens, once you identify the patients at the early stages of the disease, okay, all you do is you have a protocol of phlebotomy. So it is important to identify them early through the screening and management, to identify those patients early, to be able to start and initiate the treatment and prevent the excessive iron accumulation in the different parts of the body. So, although we know that it's probably the most common genetic condition in the North European population, it is something that is unknown or people are familiar and is not properly investigated. So it represents a major health problem for the UK. It is the transmission is through autosomal recessive, so you need to have 2 copies of the gene to see the effect. Given that about 1 in 12 they carry at least one copy of the faulty gene, you have 1/12 the carriers and about 100 that are homozygous. And those who are homozygous are more at risk for the development of the disease. Of course, you have to remember, not everyone who has the homozygous, they will develop the disease. And this is what's called genetics, the variable penetrance of the disease. So if we were talking about this condition probably 10 years ago, they probably would dismiss that very small percentage of those who are homozygous with these mutations, they will develop the disease. However, later studies, especially studies using large data sets in biobanks across the population, both in the UK and Australia, they demonstrated that actually quite a significant portion of homozygous patients develop this disease, different forms of the disease. So this is a map where you see of the disease where it's been mapped out. So you can see the homozygosity, or homozygous patients are mainly found in the United States, in Brazil, across Europe, and also in Australia, which of course they're directly immigration patterns with Europe. And here is some of the staggering statistics around the risk of the hemochromatosis patients. So a lot of them, they will present with abnormal biochemistry results. So they have raised ferritin, they have raised transferrin saturation, and they start developing, a lot of them, they will present with clinically significant iron overload. And then, of course, the risk, as you can see, increases for liver fibrosis, arthritis, liver cancer, and death, of course. Okay. Also, it's important, there's sex-specific presentation in the penetrance. Men are more likely to be affected than women. So we know, and this has been recognized even by the UK recently, that this represents almost like a low-hanging fruit for the NHS. We need to do more in order to diagnose and manage those patients. You would think, I mean, if you try to design a strategy, that actually might as well start screening everyone for the presence of those mutations, so you can identify early those who are at risk. But unfortunately, so the studies that investigate the potential of screening as a strategy, as a program, is not really the way to go about it. And the recommendation was they recommended against using genetic screening for this condition. So the way that at the moment, at present, it is addressed is that you focusing more on patients that present with symptoms or randomly identified with abnormal LFTs, liver function tests, for example. So certainly it has been recommended in the NHS long-term plan that we need to do more, and it's about how we can identify, how we can address in the disease prevention in aging well. They brought hemochromatosis as an example. And even NICE developing guidelines in order to address this. Now, one of the issues that we're having is that across nationally, if you look at nationally, there is not a harmonized, homogeneous way that you approach these patients. So there are quite differences in the way that people are investigated, and as a result, there are still patients do not have access to the best care possible across the different parts of the country. So in terms of the laboratory investigation that we do now, there are a number of tests that we have available that we can investigate patients who will present. Now, some of these patients, they will present with non-specific symptoms such as fatigue or joint pain and so on. And this will be what we'll start investigating through a series of differential diagnosis in order to eventually characterize the presence of the genetic defect. However, even within this pathway, there are significant discrepancies in the way that we approach the patients. So the biochemical markers cutoff, for example, that we use across the different labs, the disease manifestations, the different symptoms are also differentially evaluated, and also the development of complications is something that we're not sure. So as far as diagnostics is concerned, there's always there's continuous dialogue and argument and discussion around what cutoffs are we supposed to use for the ferritin or the transferrin saturation levels. So this is an example of what you expect. So you see here, you have the patients, you have the genetic predisposition, and you have those with biomedical expression of the disease and then the clinical expression. And you can see that the two markers that we use, the transferrin saturation and the ferritin, and you can see how as the biochemical expression and the clinical expression change up, the ferritin goes up, and then the transferrin saturation usually is high. So we use cutoffs around here where we can start investigating more specifically about the presence of these mutations. And of course, once we then, the patients start developing various complications, cardiomyopathy, diabetes, and so on, they will have other tests as well available to us to assess the risk. So specifically, I mean, the two main biochemical tests that we use one is called ferritin. Okay, it's acute phase protein, and this is we investigate in isolation or together with as part of the liver function test, and this can potentially we can use it to predict outcomes. However, ferritin is not specific for hemochromatosis. It's present for all kinds of different conditions, and that, of course, complicates the way that it is interpreted by the lab. And then there's, of course, the discussion whether to use different cutoffs. So we use a cutoff of 300, be more, have more narrow ranges or narrow cutoffs, or expand and to be more, to be able to get more patients investigated. The other one that we use is transferrin saturation. The problem with transferrin saturation is that it requires an additional sample, fasting sample in particular, and sometimes there's no concordance, the good concordance between the two samples. So erased transferrin saturation in one sample doesn't mean that the second one will also be erased. So typically the scenarios, the type of patients that we see coming in the lab investigated is that either there's unexplained liver disease, hepatomegaly, or elevated liver enzymes. And then, of course, you have patients coming with type 2 diabetes that have been diagnosed, or with cardiomyopathy, and these are investigated for various underlying causes, including hemochromatosis. Or the different scenario where you have patients coming in are patients without the clinical symptoms. However, because the first-degree relative has been identified as hemochromatosis, they are investigated for the presence of mutations. So, of course, those patients with positive family history, the chances of finding an abnormal mutation are high. However, in both the other two scenarios, where you present with clinical symptoms but without any evidence of hemochromatosis, the chances of identifying someone with a positive mutation are generally low. And the pathway, the differential diagnosis pathway, usually it starts from symptomatic patients, then requested ferritin or transferrin saturation. Once you identify that the transferrin saturation is high, this has been then followed with a number of further investigations that will include a genetic analysis of the gene responsible for this mutation, especially the mutation C2A2Y, which is the damaging mutation most closely associated with hemochromatosis. And then, of course, you can use ferritin in the patients in order to monitor response to treatment and so on. And most different pathways, this is the general pattern that they follow with small modifications. So, of course, this pathway, we have the issue that is not very effective. And you can see here in a study that I was done a few years back, is that they calculated in this pathway what is the effectiveness. So you can see here they counted that they started with 2,651 elevated ferritin levels. So that was the starting point. That prompted them to do more detailed iron studies, 381 iron studies, and then that resulted in 50 elevated transferrin saturations over 45. So they calculated that the number of tests to reach diagnosis, it was 7.6. And then they just carried on like that in terms of identifying the HFE genotyping, and they managed to at the end to find 13 patients that are positive for HFE mutations. So they identified that from the 2,651 elevated case of ferritin, only 13 patients, they had genetic hemochromatosis due to mutations in this gene. So their number of tests to reach diagnosis, they came with 29, which is indicator of a pathway which is not very effective. Okay? So I'm going to stop here, and Fayyaz will take over.
Thank you. Am I audible in the back? Yeah. So I'm Fayyaz. How many computer scientists are here? Just a quick show of hands. So what Dimitris has been saying so far for you guys is this is a disease we want to detect, right? So we've designed a machine learning pipeline to do exactly that. But before we get into that, I'll just briefly try to highlight the contribution made by one of my MSc students, Sanket, on this project, who actually did most of the work. So I just wanted to highlight his name here. He's not here, so most of the work has been done by him. Before we move on, I'd just like to give a bit of introduction. This is my first time presenting at this meeting, and I would like to thank Sammy, Victoria, Vicky. Thank you for organizing this. You deserve a panache. So thanks for this. It's been a really good learning experience. My lab mostly focuses on trying to get insights from biomedical data with machine learning. I try not to use the word AI because if one day we do develop AI and does something bad, but let's not get into that. So most of the time I use machine learning or data analytics in order to infer or gain insights. So typically I love working with diagnosticians like Dimitri here, or pathologists or biologists. And if they come to me with a clinical question, I can help them use data to get that insight or an answer to that question. So that's where most of my work is. There are essentially two different branches in my lab, one of them focusing on AI for biology. Just a few examples of that. We've developed an approach called RAMCLUST. What it does is it takes a sample of your blood or your urine and can identify what compounds are there. True story. We actually were funded by a beer manufacturing company trying to develop techniques that would help improve the taste of beer in Colorado, where I was at a Fulbright there. And then we found that the same approach can also be used for biological samples of like urine and other stuff, and it has been extensively used to characterize different metabolomic samples. I've also worked a lot on protein-protein interactions, so that's my other business that I do. So how do two proteins come in contact with one another? I've designed some machine learning pipelines that have been used to discover novel protein interactions. I've also been working with, had the pleasure of working with Jennifer Doudna to co-invent proteins that inhibit CRISPR. So she made proteins that can activate CRISPR or edit DNA. But how do we stop that? With anti-CRISPR proteins. And we use machine learning for that. We've also developed some methods for drug-protein interactions and protein function prediction. So if you are working in that space and would like to have a chat, feel free to meet me during tea time. Most of the work that I've been doing since 2019 at Warwick is focused on AI for imaging and health diagnostics. So for example, if you're given a histology image like the one on your screen, can we detect how long this person would survive for? What drug should that person be given? So we set up multiple machine learning methods and image analysis tools that help answer those questions. So if any pathologist in the room, by the way, histopathologist? Well, if you know someone, yeah. So, okay, so moving on. For this particular project, Dimitri came to me, as I said, with fundamentally one question. What can we do with this data of patients with hemochromatosis? Can we detect if they have a certain genotype? So that was a very well-framed question. And can we then detect if a person is going on to have develop like liver cancer or any other complications, and can we detect those sooner? So the name of the project that Dimitri mentioned, I didn't name it, ChatGPT did. So it's a backronym for FERRIQ Access Recognition Registry. So we're building a registry of these patients. It's essentially a data set. And then what we want to do is to develop a method that allows us to do intelligent quantification in that. Specifically, we want to predict whether these patients are going on to develop cancer and whether we can forecast that beforehand and whether we can detect that, or whether they are going to develop other types of abnormalities. So those are the major goals of the project. We first wanted to collect this registry. Then what we wanted to do is to do genotype-specific analysis and also develop a machine learning model that allows us to forecast these abnormalities in the future. Okay? So question number one, is it possible to predict homozygosity? So we collected some data of about 1,400 patients. Dimitri and his team did that at UHCW. They gave us the data here, some statistics out of that. And what we then did is develop a simple machine learning model. Given patient stats, can we predict if this patient is going to be homozygous or not? And Dimitri knows all about it, and you can ask him why is that important. But for us, it's very important that we design a very good predictor so that we can identify those patients that are homozygous early on. We also wanted to see if the current levels of ferritin and transferrin are optimal or not. So what you see in this plot are two types of patients. Some of them are homozygous. Those are shown as blue dots. And then you've got crosses, which are non-homozygous patients. And we've got ferritin levels and transferrin levels shown on this plot. The vertical lines and the horizontal green line that you see on this plot are the currently used cutoffs for saying whether someone's ferritin level is normal or abnormal, or whether someone's transferrin level is normal or abnormal. And what we see over here is that there is a bit of overlap between these patients, whether they're homozygous or heterozygous, depending upon how much ferritin or transferrin they have. But what we see is the higher the ferritin, the more chances of someone to be homozygous. There's an association, not causation. That's another part we need to really investigate in this project. And then we have got the same thing in terms of transferrin saturation as well. The plots on the right just show the same thing, just so we can show some box Fisher plots as well. Okay? So we developed a simple machine learning pipeline that asks a simple question. I've got measurements of a patient's, let's say their transferrin saturation, their iron, their ferritin levels, gender, age, all of that stuff. Can we predict if they are going to be homozygous or not? And what you see is if we use just the ferritin level, the AUC is not that great. So the predictability is there, but it's not that strong. But as we add more and more information, we actually get a better predictor. So we can now, just without doing any genotyping, can predict if someone is homozygous or not. So I'm going to show you some other plots on what is the contribution of each of those factors. So we did some data mining on that. And we essentially found that being a male is a terrible disease. Okay. But that essentially verifies what Dimitri was talking about. Some of those are known risk markers. We can also use forecasting, use these data to forecast if someone is going to develop any type of certain abnormalities. For example, if they are going to get an abnormal liver test sometime in the future. So what you do is, you take a patient, you measure their biological characteristics, their ferritin levels, and then you stop the time for them and try to forecast. So this is retrospective data, but what you're trying to forecast is about 12 or 18 months, how likely are they to get an elevated, let's say, ALT test? And what we found is, yes, it is possible to predict with an AUC of around 0.75, these patients that will get an abnormal ALT test right now. And that's really useful because you're essentially doing early detection of these type of liver abnormalities. Sorry, I keep on pressing that button. Okay, so we can also use the same data to try to predict if someone is going to get an abnormal diabetes marker, HbA1c. At the current time step, we measure their blood levels, and then we try to forecast it in the future. And what we found is, yeah, the predictability is there, but it's not that strong, at least for now. The current model gives you an AUC of around 0.7, and we would like to improve that. The same thing for the number of platelets. And we can increase the repertoire of diseases that we can forecast in the future from the current time step. So that's, I think I should move on to this slide now. And this shows you what type of features. So the longer the bar, the more important that particular feature is for that particular disease. For example, for ALT, the homozygosity is a very important predictor for the patient's raised ALTs 12 or 18 months in the future. And the same thing for, in terms of diabetes, of course, age is a known confounding factor there. And what we would like to develop further is, can we get an age-independent risk predictor of this? The same thing for raised platelet counts or abnormal platelet counts. Can we get some, what type of features like transferrin saturation is the most important predictor of someone's abnormal platelet counts in the future? Okay. So at conclusions, so our preliminary results show that it is possible to do both things. First of all, predict homozygosity and predict the future risk of certain diseases. So the project is like, I wouldn't say it's complete. We're just beginning to scratch the surface of what we can do with this data. But this is a good start. And if you're interested in working with us, we actually don't have we weren't able to hire a data scientist. So most of the work was done by my MSc student. So if you're interested in working with us, please join us. We tried a couple of times. Data scientists are in really high demand. So whatever we are offering them, the industry is offering double of that. So, but we're looking for some really dedicated people to come work with us, and you'll be taken very well. You'll be very well taken care of, and we have a very good impact to make. If you have any questions, I think we should be okay for that.